Hello, my name is Dr. Francoise Cluzeau. I am the Associate Director for NICE International, and together with my colleague Dr. Ryan Lee, who is an advisor also for NICE International, we are going to tell you about the role of NICE in establishing guidelines and quality standards. We will tell you about its role, about the structure, its funding and how it is governed. We will tell you about the processes and methods for developing NICE guidelines and quality standards, how to help implement NICE guidance and pay for performance, how the work of NICE can improve care quality, and also how we can learn from other countries. So what is NICE? NICE is an acronym which stands for the National Institute for Health and Care Excellence. It is the independent organization in terms of its governance and the decision-making process. It is responsible for providing national guidance for England and Wales, covering about 70 million people, on advice to improve health of the population and also social care that it may receive. As an organization, NICE can be classified into 4 dimensions. It is a non-governmental agency. It is independent in the way it is governed and the way also it makes decisions. However, it is funded by the Department of Health, which is a department of the UK government. It has a board of 10 non-executive members and a chair who is appointed by the Secretary of State, and it also includes executive members of NICE and the chief executive. NICE's role can be divided broadly into 3 areas. In the red box, you can see that one of its roles is to reduce variation in the availability and quality of treatment and care. In the green box, NICE can help resolve uncertainty about which medicine and treatments work best and which of those represent best value for money for the entire National Health Service. And in the purple box, NICE sets national standards on how people with certain conditions and diseases should be treated. NICE produces a whole range of guidance and products, and this includes medicine and drugs, treatments, procedures, surgical procedures, diagnostics and devices. It also produces clinical guidelines for a whole range of diseases, from chronic diseases to maternal and child care, mental health and pathways. It also produces quality standards, performance metrics, and a whole range of information services for those who receive care, but also those who provide commissioning and managing services across the whole spectrum of health and social care. NICE's guidance is produced in 3 centres, supported by a range of services. On the left-hand side, you can see the Clinical Practice Centre develops clinical guidelines, Medicine and Prescribing Centre, Safe Staffing Guideline, how many staff should be involved, doctors, nurses, and training. In the middle, you have the Health Technology Evaluation Centre that provides guidance on technology appraisals, drugs, surgical intervention, devices diagnostics, patient access scheme, scientific advice to manufacturers, and research and development. And lastly, the Health and Social Care Centre takes care of quality standards, NICE pathways, social care advice, prevention of diseases, accreditation of non-NICE guidance, and the Public Involvement Unit. And these are supported by implementation team, business planning and resources, including IT, evidence resources, and communication. And NICE International is one of the divisions at NICE. If we turn to the funding expenditure and those 2 pie charts, on the left-hand side, you can see how the funding comes from for NICE, and you can see that the vast majority of the funding comes from the Department of Health, from the government of the UK. On the right-hand side, the pie chart describes how the money is spent, expenditure, and this is broadly divided into 3 areas, and most of which comes from the salaries, about 600 staff at NICE, but also external contracts to universities and also professional organization that provides systematic reviews and are commissioned by NICE to develop its guidance. NICE's works on a number of core principles. First one is that we always use the best evidence to develop guidance. Secondly, it is very inclusive. All stakeholders are involved in the development of the guidance, from healthcare professionals and also patients. The guidance is very transparent. All the workings are available on the NICE website and available free of use. NICE is independent in its decision making and its committees. However, because it is publicly funded, the public has a right to challenge NICE and can take it to court. NICE reviews its guidance very regularly, about every 3 years. It provides support for implementation in practice, and it provides its guidance on a very timely basis. but ultimately NICE is accountable for being reasonable in the decision it makes.
Well, NICE guidelines were needed to address this variation in care and health outcomes across the UK. Different patients across the UK were receiving different kinds of care, even if they may have had the same condition, and at the same time there were lots of different pieces of guidance coming from different professional medical associations, and this was before NICE was established in 1999. We call this the postcode lottery. And so NICE was given the role to develop clinical guidance, so to do two things. One is to promote cost-effective use of NHS resources, not just cost-effective, but ensuring the same or similar practice is done across the health system, so that different patients should be treated in the same way if they have the same needs. And secondly, this is done using the best available evidence of clinical and cost effectiveness through a participatory process, a process that includes different stakeholders' inputs and not just about synthesizing some clinical trials, but stakeholders play a role in shaping the recommendations by NICE. So what are NICE clinical guidelines? Well, one, it's a piece of broad guidance that covers management of a particular condition, usually covering the whole pathway of care from diagnosis to treatment to long-term rehabilitation and so on. And normally one guideline focuses on one disease area, like hypertension you see there, diabetes, depression, and so on. Secondly, NICE guidelines consider both clinical and cost effectiveness, and we also include patients or carers in the committee that looks at the evidence, so that they can bring their perspective to shape the recommendations. Thirdly, if NICE has already conducted a health technology assessment or some other guidance that's relevant to this condition, so it may be an HTA on a hypertension drug, then this would just be adopted within the hypertension clinical guideline, which makes sense because you don't want to duplicate the work, waste money, and you want your guidance to be consistent across different NICE programs. Finally, NICE clinical guideline recommendations are advisory, they're not mandatory. So doctors and other clinicians, they don't have to follow everything in the guideline, and that allows room for clinical judgment. But also, as Francoise will discuss later, we have different levers to encourage clinicians to follow recommendations. And we also develop what we call quality standards to help measure and improve practice. So the idea of quality standards is to look at the health system as it is now and try to see if we can prioritize 6 or 8 of those recommendations that make sense to where you need targeted quality improvement. And these quality standards will include both a set of statements describing what best practice looks like, as well as associated indicators, so process indicators, as well as structural indicators and sometimes outcome indicators, to describe what you need to measure and what's the target for quality improvement. So this diagram shows that NICE quality standards define best practice. So we're aiming towards the right hand side of the curve there. They don't list all minimum required standards for regulatory purposes. So to give you an example, this is a set of a NICE recommendation from a clinical guideline on stroke and how that's been adapted into a quality standard which can be measured and to drive quality improvement. So you can see there, the quality standard really spells out in practice what good care or best care looks like. Now, I mentioned briefly about the different people involved in the NICE guideline development. So here is a representation of the various different groups. So starting with NICE in the center. NICE doesn't actually do the work to develop clinical guidelines. What we do is to establish the process and methods for guideline development, but we outsource most of the technical work, the convening work, to national collaborating centres around the United Kingdom. So we call them NCCs, and NCCs are part of the medical association, so the Royal Colleges, and it's a centre where we have the clinical experts who also have a good knowledge of evidence-based medicine, usually leading the centres, and they have teams of technical staff such as systematic reviewers, health economists, information scientists, as well as editorial staff and project management staff and research assistants together to do the evidence search for the NICE guidelines, review the clinical trials, convene meetings involving the guideline committee, and so on. Now, the committees, the Guideline Development Groups, or the GDG, their role is to review the evidence base that's presented to them by the collaborating centres, and to meet together and to make recommendations. So a bit more about the guideline development process. So this is a systematic process with stakeholder participation throughout. And I won't go into all this in detail, but important to note in the purple boxes, scoping is a really important part of the process. So this scope of the guideline, what the guideline will cover, what it won't cover, this is important for everyone to agree up front. And the GDG consists of a multidisciplinary committee with different experts relating to the clinical condition. It will be led by a chair. So I want to mention about the clinical and academic experts, so not just medical doctors, but depending on which condition we're dealing with, includes other disciplines too, so nurses, physiotherapists, psychotherapists, psychologists, pharmacists, social workers, and very importantly, patients, carers and lay members. They provide important input into the process because they see the condition, they see the evidence not from the eyes of a clinical expert, but from experts in their own right, from experiencing the condition. So their view on what the recommendations are is very important, and we take that very seriously at NICE. Now, GDG members bring their own expertise, so they have different perspective, but they don't represent a particular organisation or a particular hospital, particular body, or so on. And all members have equal status, regardless of how senior they may be in their different professional roles. The other thing to note is that GDG members are recruited openly through advertisements on the websites, and NICE and the NCCs, we make active efforts to engage different stakeholder groups like professional associations as well as patient organisations to in this recruitment process. And really the key role of the GDG is to make judgments, make difficult judgments based on the evidence presented to them. They not only have to look at effectiveness and cost effectiveness, but they also have to think about wider ethical, social values. What happens if we make this recommendation? Is it possible to overturn it? What impact would it have when you try to implement it? Is it feasible? Are there any legal or policy constraints? So the role of the GDG is not easy at all, and that's why we need different members from different disciplines, all with different expertise and perspectives, to try to come to a decision or set of decisions in the guideline that is not necessarily going to please everyone. It's not going to make everyone happy, but at least they've considered all of the different factors and they come to a reasonable conclusion through a reasonable process.
There are many ways to help users implement NICE guidance and to comply with it, and we will describe some of the approaches now. For example, there are various tools such as baseline assessment of current practice, cost impact of implementing the guidance, there are educational tools, there are sharing examples of improvement at local levels, and then there is also the use of financial incentives and whether they work. And ultimately, what is the impact of NICE guidance? This slide shows an example of a baseline assessment tool for a NICE guideline on pressure ulcers. This is a screenshot of an Excel spreadsheet, and as you can see, the recommendations from the guidelines are on the left-hand side, and then there are columns on the right-hand side that allow users to evaluate their current practice for each recommendation on a number of indicators and also to monitor their use over time. And this Excel spreadsheet can be used as an audit record of practice as users go along. This baseline assessment should always be used in conjunction with the guidelines they relate to. NICE provides a cost statement tool to help its users cost the impact of implementing a particular guideline. And this slide shows an example of a cost statement for diabetes in pregnancy. As you can see, the recommendation in orange provides pregnant women advice with type 2 diabetes on testing their fasting. And clinical experts have estimated that implementing the recommendations could double the number of testing strips for the NHS, and therefore, as you can see in table 1 below, this would lead to a cost impact of around £135,000 or $200,000 for the UK, which is a minimal cost. NICE also produces an online self-learning tool in conjunction with the British Medical Journal for its guidance, and this is posted on the BMJ website free of charge. This is a screenshot of the learning module for complication in pregnancy in primary care. And what this does is that it enables users to understand the role of NICE guidance in helping users to put evidence into practice, how guidance is developed, and who is involved by taking them through a menu electronically. NICE also makes available on its website examples of case studies that demonstrate improvement based on utilizing the NICE guidance and that can be shared with other practices. This slide shows an example of a case study on reducing antibiotics prescribing for coughs and colds in primary care following the implementation of NICE guidance in a practice. And the authors found that antibiotic prescribing for coughs reduced from 54.5% to 37.7% in 3 months in their practice, leading to an estimated over 700 fewer prescriptions in 1 year. And in this case, the authors offered some lessons from their experience and also some important factors that were taken into account in implementing the guidance. The buy-in of all the staff from across the practices was important, as well as reinforcing the message to all the clinicians, as well as involving all the staff in the early stages of implementation. Pay for performance is becoming increasingly cited as a lever to improve compliance with guidance. The Quality Outcomes Framework, or QOF, is a pay for performance in primary care, which was introduced in 2004. It is a voluntary annual incentive scheme, and it rewards family doctors in the UK for improving care for their patients. And general practitioners get achievement points for 3 major conditions: managing common diseases, asthma and diabetes, implementing preventative measures such as checking blood pressure, and also targeting hard-to-reach or at-risk groups, particularly for vaccination and screening. There are 75 indicators in the QOF across 25 disease areas, and NICE develops indicators based on NICE guidelines or quality standards. How does the QOF work? The QOF is based on a point system. The primary care practices are scored on the 75 indicators that I mentioned across the 4 domains, and the higher score they achieve, the higher their income that is adjusted for caseloads and case mix of their patients. And this can lead to significant costs to the NHS, about $1 billion a year, accounting for 15% of primary care costs, but also accounts for about 15% of GP income. So does the QOF lead to improvement? Well, it definitely improves the recording of information. It also improves the process on the whole. However, intermediate and proxy outcomes are unclear. It is also unclear to what extent it improves clinical outcomes. For example, initial improvements that were observed at the beginning of the QOF fell back to pre-existing trends, and this suggests that this is perhaps a process-driven exercise. However, there is evidence that the poorest performing practices have improved the most with narrowing inequalities of care. Another way of helping to enforce compliance is the opposite of rewarding for practice, but it is to impose financial penalties to providers who do not comply with guidance. And this is an example of a NICE guidelines that was published on management of deep vein thrombosis in 2010. As you can see, this is a screenshot from the BBC News at the time the guideline was published. The guideline recommended that all patients that were admitted to hospital in England and Wales and Northern Ireland should be assessed for the risk of dangerous blood clots. And this is because at the time 225,000 people died unnecessarily from DVT every year. And therefore the ministers decreed that hospitals that do not follow NICE guidance and do not screen at least 90% of their patients on admission will be penalized by withholding 0.3% of their income. So has this approach worked? Well, as this slide shows, published study on the impact assessment, which was based on a mandatory quarterly data collection by all hospitals from July 2010, when the NICE guideline was published, to December 2012, showed that there was a steady and significant increase in the proportion of patients screened for VTE in all NHS hospitals from 47% to 94% during the 2.5 years, as demonstrated on this graph. However, a more recent study published in 2013 has found that although the documentation and the recording improved, it was less clear whether this has led to improved patient safety with regards to prescribing appropriate prophylaxis. So I think this shows that really, despite all efforts and tools deployed for implementing NICE guidance and compliance, this is not a panacea. Certain approaches work, some better than others, but ultimately this is put to the test in measuring how well the NICE guidance has done in practice.
Now, I want to say a bit about the work we do at NICE International. NICE International supports governments from different countries all over the world to help them make better decisions, better policy decisions for better health. So this means making better use of evidence, including guidelines, quality standards, health technology assessments, as a means of improving population health and to achieve and sustain the goals of universal health coverage. Very important to note that our work is not only about providing technical support, but we also support countries in establishing the process and the governance mechanisms that are really essential and really what makes NICE work in the UK so well respected and trusted and robust.
And through working with policymakers and clinicians on the ground, we hope to be able to build institutional and technical capacity so that the country is able to use evidence to make better decisions for the health system. This means working jointly around a specific project, like an example I'm now going to give. An example of developing quality standards for stroke care in Vietnam.
So the Vietnamese government has been making efforts to roll out universal health coverage, and as part of this effort, improving the quality of care in hospitals across the various tiers has been a really focal issue for the Ministry of Health. So they approached NICE International to support them in developing evidence-informed quality standards based on robust evidence and a nationally owned process. And with our support, a situation analysis was undertaken, and this found stroke to be the major disease burden, the major killer in Vietnam, accounting for 230,000 cases per year and 110,000 deaths. Now, NICE International and the Royal College of Physicians and NHS England have been working together already in different countries as well as the UK to help develop clinical quality indicators and stroke quality improvement worldwide. So this time working with the Ministry of Health, a multi-stakeholder quality standards committee was convened, and this comprised both the provincial and Ministry of Health policymakers, as well as stroke clinicians and hospital administrators across Vietnam. And in 3 workshops held in Hanoi, the committee identified clinical guidelines based on evidence, both from Vietnam as well as in the UK, and we selected relevant recommendations to address what were high priority clinical areas for improvement in stroke care in Vietnam. And taking these recommendations, we developed quality statements and measurable indicators appropriate to the Vietnamese context. And the final product was approved by the Vice Minister of Health. So this has been a very good experience both for the Vietnamese and for NICE International as a model of national and international partnership. Through NICE International and our colleagues at the Royal College of Physicians, we formed an effective partnership with local policymakers and clinicians, and this was the first time that stroke clinicians were able to articulate their needs for quality improvement, building of stroke care units, for example, and that was seen to have a direct policy impact in how the policymakers decided what the policy should be. And this also helped to strengthen the policy as well as the clinical institutions in Vietnam. So since the quality standard process, the Ministry of Health has now incorporated the quality standard as part of their hospital quality accreditation criteria, and they have gone on to, through World Bank project funding, they have started to plan and pilot implementation of the quality standards in a number of provincial hospitals in northern Vietnam. And finally, we hope that this quality standard will lead to better decisions by policymakers and by clinicians, because the QS focuses on low-cost, high-impact interventions, looking at prevention of stroke, joint working across disciplines, early diagnosis of stroke, and early rehabilitation. And by implementing all of these quality standards fully across Vietnam, this could lead to improved care for 115,000 patients, with net savings of $2.8 million to the Vietnamese health system. So this partnership has been successful, and we see it as something that can be replicated in other low and middle income countries aspiring towards universal health coverage. So thank you for your attention, and we hope you found this webinar useful.